Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research. And we're here to explore a wide range of topics with you through interviews with content experts.
Welcome, listeners, to another podcast from our 2021 hybrid AAOMPT Conference. In this case, we're continuing to do our interviews with the various presenters during the conference. And I have the privilege of speaking to Megan Donaldson, Moyo Tillery, as well as Ngozi Akataobi. And we are going to discuss aspects of their very important talk, at least in my mind, an extremely important talk that was titled OMPT Straight Talk, Conversations About Race for Improved Healthcare. Now, before we dive into the questions, I'm just going to ask our presenters to give a little bit of background about them, including where you're currently at, but also from a fellowship standpoint, which program you went to. That way we get a kind of an idea of where you're coming from. So with that being said, and Ngozi, do you mind starting off?
Sure. Thanks for having us, Kevin. My name is Ngozi Akataobi. I am located in Philadelphia. I work mainly in an outpatient setting, mainly just general orthopedics. I went through NIOPS fellowship, finished in 2017, and shortly after relocated from Texas to Philadelphia, from Dallas to Philadelphia. I also am an adjunct for Baylor's Baylor University's DPT program. Most of my patients, I see a pretty large population of spine patients, but I get a bit of everything.
Thank you, Ngozi. Megan, do you mind going next?
Absolutely. Thank you. So Megan Donaldson, and I am the program director at Tufts University in Boston for the DPT program. And I'm 13 years an educator. I like to prefer to myself to think I still have some clinical relevance. I was in the clinic up until just before COVID. And with that, 21 years of PT experience. So I've been around for a little while. And my fellowship was actually at Damon College. So that program has since sunsetted, but still know great people from that program, and obviously the rest of the fellows. You may also recognize that I'm on the board and I'm the conference chair.
Yes, I do recognize that, Megan. You are found pretty much everywhere anytime I'm involved with AAOMPT. And then Moyo, is it okay if I call you Mo?
Yes, please.
Perfect. Mo, do you mind giving us your background?
Sure. So my name is Moyo Tillery. I go by Mo. I work in outpatient orthopedics. I've been a physical therapist for 10 years, and I primarily work in occupational health. And so a lot of our patients are injured workers, which comes with a lot of spine, but pretty much anything from head to toe. My fellowship is through MTI, that's the Manual Therapy Institute, and I think that's all you asked for.
That is a very perfect answer. So with that being said, all three of you very, very adamantly saying there's a stage that needs to be set for this conversation. That way our audience has context. They can apply that a little bit better. Megan, do you mind kind of speaking to that and setting that stage?
Absolutely. Thanks, Kevin. So, conversations really do humanize us quite a bit, and it's really about our approach and the way that we interact with our patients. To develop that empathy, that patient-centeredness, we really do have to think about not just the style in which we approach the conversations, but really the intentionality. And some of that is because we have our own implicit bias. We have biases that frame us, that shape us. And we have to do our own work here, right? And we have to recognize it. So some of that comes from this session. But with that awareness, then we want to set the stage before we have a conversation with the patient, just to make sure that we're making them feel comfortable, right? That we're not coming in ready for this conversation. Maybe the patient isn't. And so we really wanted to approach it from a clinician perspective, not just an educator researcher perspective, like what does the research say? We wanted to put the OMPT feel on it because it is so critical before we touch a patient that we build trust, that we build that relationship, that when our hands go on, that it means helpfulness rather than harm, or maybe there's some, I guess, some worry on the patient's behalf, or maybe a barrier that we haven't yet explored or worked through. So, what we talked about in our session, and we really wanted to make sure that we addressed, was obviously implicit biases or unmet patient expectations if we didn't address the challenge directly. So, thus, we wanted to do some engaged communication strategies about race, and that was really some of our framing.
And Megan, to go off script a little bit, you did, if I recall, offer some references or some sites regarding implicit bias testing. And what we'll end up doing is within the show notes, we'll put some links. That way, individuals who just aren't familiar with that term or whatnot can really kind of have a bit of awakening. I remember the first time I took those tests, I was like, wow, that was not what I was expecting. So thank you very much for setting the stage, and we'll move on. And Ngozi, if you don't mind, I have a question for you. And this one was looking at the descriptor for this presentation. It said that this talk was it was necessary for OMPT practitioners to facilitate these conversations that cultivate understanding about race and diversity. And I 100% agree with that. But one of the things that I wanted to understand was where did this concept for the talk originate? Where did it come from? Was there a shared experience across the three presenters? Can you give us that background?
Sure. So it's actually interesting. This talk came about because I had to meet with Megan. I am on the DEI task force for AAOMPT, and I was selected to be the liaison between the task force and the conference committee. So Megan and I, this first time that we met, we had quite an interesting conversation. We had conversation, obviously, about the conference itself and some of the suggestions that the task force had, but it led into some other conversations about my own personal experiences, being part of AAOMPT, and just kind of in my life, my personal experiences, and actually ended up with really, I think, kind of had a place where we really kind of connected through that talk. And the next thing I knew, I think it was the next week, or maybe even a couple days later. I think it was a couple days later, actually, because if I recall, this was a Friday. And that weekend, I was checking my email, and I had an email from Megan who said basically she was thinking a lot about our conversation and had this idea for a talk, and if I would be interested in it. And here we are. Megan, do you have anything else to say to that?
Well, see, I don't sleep a lot. And so when I don't sleep, ideas just generate in my head. And then I think it was like at 3 a.m., I got up on a Saturday and was like, oh, we have to do a talk. We have to talk about this. Ngozi brought up something that just resonated with me, which was the feeling of isolation, the feeling of not being included at times. And that really just, it sat with me because certainly you never want any person to feel that way. And that is really the framing. And we talked about race as an essence of that. And I really felt like this story has to get out there. And then I knew Mo. And then I was like, I think I have some incredible women to put on a stage and have this conversation. And so the storyline was I reached out to Mo and I said, Mo, I think I have a thing I would like to try to have the three of us do together. And I'd love for her to be a part of it because I think I have two incredibly powerful women colleagues sitting here with me, and that they have unique stories and they've had backgrounds that have been different than mine. And I really felt that it was really nice to have their perspective as we were trying to grow in this vision together and really try to be inclusive and thoughtful of diversity, especially in AAOMPT's presentations, as well as in the rest of the conference material.
If I remember correctly, the email came in at 5 a.m.
on Saturday.
on a Sunday or a Saturday. That is correct.
I was up at 3. I text by 5, so that's about right.
Mo, do you want to add in a little bit to that to establish your connection here a little bit more, and what drove you to say, like, yes, this is something I want to be part of, and besides potentially being coerced a little bit by Megan Megan does have the key aspect of a true mentor. She's very capable of pushing you right to the edge of the amount of discomfort you need for action to occur.
That was well said. And that's really what happened. It was a conversation that needed to be had. And so I think that Megan's recognition of someone having a story to tell, I think actually resonated with me in saying that her recognizing this conversation needs to happen made me think about all the other conversations that are going to happen as a result of this conversation. So for me, it was a no-brainer. Just like Ngozi, just like Megan, just like you, Kevin, you probably have a personal story, whether it's race related or not, that you would like to tell someone that could be really impactful. So I knew that this is something that I needed to be a part of. She voluntold me and I accepted.
There is a shared theme there. More about the voluntold, but also about the communication aspect and having that story to tell. Now, there were a few times during the talk where the audience was put into a little bit of a situation where discomfort should occur and did occur. One of those times was where you guys asked a question, and that question was, what word would you use to describe how you feel when you talk about race? And there were various different answers. There were everything from confused. There were several different emotions. One of the questions I had to return to you guys is, each of you, what was the word that came to you when creating that? And in order to maintain a little bit of organization, I'm just going to go in reverse order from the intro. So Mo, that would put you first. What word comes to your mind?
I appreciate this question. And I thought about it for a while. And so today, I think the word is empowered. But 10 years ago, as a PT student, it would have been afraid. Right now, it's an empowering conversation to have. But, kind of like we talked about the continuum, we're all in a different stage. And so I think that word is going to change depending on when you ask someone. So it'll be interesting to ask this question, I don't know, next conference and say, what are your words now? I think as we have these conversations, that'll change. But long story short, I think I'm going to go with empower.
There is, just for the listeners, I want to say that there is so much to dive into with all of these answers. I'm almost saddened with the fact that this is a short form, or at least a medium form podcast. So there are going to be several times where you're probably not going to be happy with us moving forward with the conversation, but that's more from the time. This is a conversation, however, that should not stop. So I'll preface that now. Normally I would hold that to the end, but I have a feeling that there's going to be a little bit of anger that might rise into some listeners because we don't dive into that. But there was so much there that deserved that I do want to dive into. Let's finish the round, however, if we can. Megan, do you mind giving us your words?
Engaged. I really feel like we needed to be at this stage. We need to be engaged in this conversation. And, I resonate with the words that were on the screen. I know in stages I was at those phases, and I recognize what Mo said. It is that journey and trajectory. And sometimes, you're put in a situation where some of those words that were on the stage came back. But now, where I'm at, I'm engaged. I'm engaged in the conversation.
Ngozi?
To Mo's point, I agree that it can be on a continuum, and actually for me, I think that continuum changes sometimes on a day-to-day basis, and really just it depends on my audience, I think. For me, at the conference itself, I would say that there was quite a bit of motivation that I felt. The fact that we could actually have this conversation in this space where it could get to a lot of people. But I know that there are times where I feel pretty apprehensive having conversations about it, because the reality is these conversations are not always well received. And that's kind of where I am in my journey with this. It changes. Sometimes I feel relieved. Sometimes I feel empowered, like Mo said. Sometimes I feel motivated. But yeah, I think that it really just, for me, depends on my audience.
Spectrum was mentioned a couple of times across all of your responses. And there is definitely a wide spectrum in my mind when we go from afraid to empowered. Engaged, obviously, is another level within there. The frequent changes based off of your audience. This points me to a question more for Mo here regarding what was titled the developmental model of intercultural sensitivity. And my interpretation was there's this hope for evolution from an ethnocentric to an ethno-relative stage. What does that mean? What does that look like? Can you describe this continuum a little bit for us?
Yeah, thank you, Kevin, for that question. It's I think we touched on this a little bit in the presentation with some of the examples. So I think these concepts can be a little hard to grasp. And so, the perfect example is thinking about being sort of self-centered, very ethnocentric, fixed into your experiences and not being able to engage, to use Megan's word, in someone else's experience. So you don't have to share the experience, but you can engage in the experience. And so the inability to do that can look like being colorblind, not seeing race because it hasn't been a part of one's journey. And that's fine, right? I think that's a part of the continuum. You have to start somewhere. And then moving through could be, after you've had a couple of conversations, you're now able to engage in a conversation with someone who has a different experience. And, you can draw from examples of shared experiences now. So whether it's race related or not, it could be because my race made me feel isolated. You can say, oh, there was a time when, I was on the playground in preschool and I felt like no one wanted to play with me, and everyone can kind of resonate with that. And so that's sort of, an example of moving through the continuum to where you can say, all right, I can put myself in your shoes, Ngozi, and say, I really understand how you feel. I was not there with you, but when you're fully engaged and you can sort of put yourself in someone else's shoe, you've broadened your scope to being more ethno-relative. It's less specific, less focused. So in this case, you're actually going from very, very specific, narrow focus, tunnel vision to a really broad kind of worldview of someone else's experience. And so, we've talked about the continuum. It'll be different every 30 minutes, 20 minutes, hour, week. But it does depend on your audience. It depends on the situation. And I think that acknowledging that it's a continuum is the best way to start having these conversations.
I'll just kind of link this right back to the implicit bias piece, which is really that being that conscious about your bias and really where you are. It does impact how you treat people. And it's kind of that emotional intelligence to a different extreme, right? We are aware of others, but we also can bring race into it, where it is an experience of not just how the person feels, but how they feel about the color of their skin and how that impacts their life, and what impact that has had over the course of their life, and to feel included or to not feel included. I remember Ngozi's stories. I remember Mo's stories. I mean, we truly had a great time in this conversation, but we actually walked through a lot of these examples because we were talking about what this felt like in all three of our different stories. And I just want to say that this application of this model with an awareness of your own bias can really be a tool for people to use clinically, professionally. It's a great tool, and there's great resources. So Kevin, we'll make sure you get that link, but I think this is a great tool to highlight to people as well.
I would just add to that, just kind of really re-emphasize that this is a personal journey. For everybody's journey through this looks different. And like Mo said, from day to day, from situation to situation, that can change. And realizing that is important, and being okay with that is important as well.
So it's a really good framework for us to consider where we're at in our own journey, and as we get more guides, as we get more understanding, how far an individual has to go in that journey, and knowing ultimately that there's probably not an endpoint. But my next question involves an endpoint that for a very long time I thought was the right endpoint when we speak specifically about race. And I'm interested in your vantage points, especially when I hear the terms in your responses of a broad worldview or others. I don't see color. I don't see race. The goal of like us all being one. How do we feel about that? What are our thoughts about that color blindness? Is it the right direction? Is it the wrong direction? What are your thoughts?
Kevin, if I may, I would beg to sort of extend grace to that mindset. I don't think it's wrong, kind of like we said. I think it would sort of be a double standard to say, I need you to walk in my shoes, and we're not willing to potentially walk in someone else's shoes who is colorblind. I would want to have that conversation to understand their perspective, because it's theirs. And that's kind of what Ngozi just said. It's not wrong, it's someone else's. And so I think it's a beginning point for that person on the continuum to understand where they fall in, where they want to go. Are they fine being where they are? Does it impact their life, their patients? Going back to patient care, right? Their colleagues. So if our position has adverse consequences, then yeah, it's not okay, right? And even if there are no adverse consequences, you can potentially sort of miss out on really meaningful, impactful relationships and conversations that you can have. So I'm sort of on the middle ground on that position. I think it can go both ways.
I'll just add, this is something that I have heard growing up, and I recognize the color of my skin. And I have to say that people were judging you if you saw color, right? You don't talk about color because that's wrong. And so I think that there was shame associated if you saw color. But I'm not colorblind. I see color. And the reality is just to talk about it doesn't make it wrong. And there's no shame in it. And one of the frames that we used was race, right? Reduce anxiety by talking about race anyway. And we wanted to put it out there where we say, I do see your color. I see your beautiful color skin, right? And how do we talk about that in a way that it doesn't feel like I don't see you, I do see you, and make that okay. Make it okay, and not shameful. Like it's not wrong to talk about a Black woman or a Black man and a white woman or a white man. It's not wrong. We just have to accept where we are with it and move forward. So that connection isn't limited by the barrier of which we've put forward by ourselves because we're uncomfortable. And that's that implicit bias again that I think kind of resonates here as well. But I want to say we see color. Unless you're colorblind, we see color.
Yeah, I agree with you, Megan. I want to kind of piggyback off of that. The reality is we do see color, and so we can't deny that. I am a Black woman in this world. I am also the daughter of two Nigerian immigrants. And for you to say that you don't see color also just erases a part of my experience. And part of getting to this place where we're trying to get with this framework, with this talk, is understanding other people's experiences. And so to say that you're colorblind, I think goes against that. Color blindness, I think, like Megan said, was we grew up talking about I don't see color. The reason for that was kind of in response to years and years of racism, right? So this came about and there was a reason for it, but the impact of that has been that none of us are comfortable talking about race. And that's why we're here. It's because we don't talk, we've been told to not talk about things like politics and race and all of these things. And because of that, when we are put in those positions, it's very uncomfortable. It's very awkward. There's defensiveness involved with that. And to get through that, it's just going right back to our framework and tying that right back in. You have to just start talking about it. And by talking about it, the first step is acknowledging that we do actually see race. And you have to also acknowledge that we see differences in the lived experiences of different groups in this country.
I will sit here and I will just continue to just think about everything each one of you have said. Now, there's a little bit of action that was provided during this talk. And Megan, you did kind of touch on it, but I'll probably gear the next portion of it to Ngozi. And that was the race framework. So Megan, you mentioned it was built off that framework, or reduce anxiety by talking about race anyway. There's an A, a C, and an E to the rest of that acronym. And Ngozi, do you mind taking the first one, and then Mo, if you wanted to take C, and then Megan, if you wanted to close the loop with E, that I'm perfectly fine with that.
Sure. The A portion of this framework is to accept that anything related to race is either going to be visible or invisible. And this ties right back into what we were just talking about with color blindness. So what we have to remember with this framework is this is a tool that is being used to try to start these conversations about race. And so the point of this part of the framework is to accept that people are going to be on two different ends of the spectrum. For some people, they are of the mindset that race is invisible. They are colorblind. They don't see race. But that can be harmful, like we just spoke about. The other end of that, the other polar end of that, is being hyper visible, right? And so what comes from that is maybe some defensiveness, and so it doesn't make for a place where you can start a conversation fruitfully. The goal is to find somewhere in the middle where we are recognizing that race is visible. We can see it, starting there, trying to start somewhere in the middle, find a space between the two extremes, so that you can have a starting point for the conversation.
So, Kevin, I heard you say that you would like for me to talk about the C part of the framework. And this is where Ngozi did an excellent job speaking about calling on our allies. I think I found this really enlightening as well, because there are types of allies. And so part of working through this is knowing what kind of ally you want to be, or need to call on. And so Ngozi presents a few options: internal allies versus external allies. And it's situational, of course, like we've sort of indicated through this talk. If you may have to call on both, have resources across the ally world, if you will. But I think the key point here is to not lose sight of the community or the individual in need. They should always be at the center of support. if you are going to choose to be an ally or if you're looking for an ally. So just kind of remembering not to have the ally become the focus. Kind of stay centered on the common goal that you're trying to achieve, and finding out, we do provide a few resources for how to locate community allies, or like in this situation, individual mentors and people who just are comfortable having these conversations.
I'll just jump in and add a bit there too. I think that the big take home message for this portion is we're not experts. I'm not an expert. I have limited knowledge, and my knowledge and my perspective is framed by my personal experiences and my biases as well. And that's why it's important to call on allies for support, both internal and external, as Mo was saying.
And then you had asked me to talk about E. And so this is really that expect that you're going to need to provide some answers, some practical tools, and some frameworks. And so what we did in the presentation was do that. We provided some tools that we thought would be helpful. There's a toolkit that we referenced. It's a toolkit for talking about race, bias, and change. Surely we can get you that link if you would like that to check that out. I think sometimes I want to simplify this by saying read, watch, and then do better. Read, watch, and then do better, because we really need to utilize the information that's out there, resonate with it, think about it, and then put it in application. And whether that's with the next patient you treat or whether that's your colleague that you're working with, this isn't hard. It just takes the effort that we have to put what we read, what we watch, and put it into application. And truly, we have a mutual purpose with our patient. We want them to get better. They want to get better. We have mutual respect. We should establish that. And so really with that journey, any conversation really can happen. And so if we use the right tools and framework, race is not as intimidating as one would think if you use some of the tools to guide the conversation.
So a little off script, one of the things that you have said is guide, meeting them in the middle, really listening to the other person and trying to make that deeper connection. Sounds like motivational interviewing to me. Is that a theme? Can you give us a little bit, Megan? You specifically have said "MI" a couple of times, so do you want to give us a little bit of insight on how that came into this discussion?
Yeah, I really like motivational interviewing. I will say that I've done motivational interviewing for well over 15 years. I was trained in it. I teach courses in it. I've done it quite a bit. I have found that our approach to really having a patient-centered care approach really requires us to have a style of motivational interviewing, which is curiosity, it's inquisitiveness. It is not coming to the patient with a direct question, expecting them to give you a 1 or 2 word answer and moving on. I think we need to change the script. I think as future generation and leaders that we need to think about how health services are provided, for social inequities to be removed, for us to really address things. We have to have conversations. It can't be 1 to 2 questions, get your answer, move on. MI allows space for conversation. And the other phase of motivational interviewing is then effective listening. Did you listen to what your person, patient, client just said? And if you didn't, that's an opportunity for you to grow. And so I call this out on students. We talk about it as clinician colleagues. I call it out on mentors and fellows, right? I call it out on myself. I don't listen to my husband sometimes, right? Like this is real life skills, but we practice them. So I ask back to myself, to patients, to students, did you listen or did you hear? And so I think sometimes we hear people, but we didn't really listen. And we have to work through that. We get in our rut, we get in the day-to-day routines of the clinic. And I recognize that some people think MI takes too much time. I would push back on that. There's evidence to support that doesn't take that much time. And the outcomes are actually much more significant after 1 MI session. and one MI session appropriate to that patient, whether it be race, whether it be an intervention, whether it be whatnot. We address the barriers and we work through it, and it can be very effective. So I may have said that there's a little bit of frame on MI when we talked about all of this, but I'll let the ladies speak to anything else.
No, I think Megan really hit the nail on the head with this particular overarching principle of the talk. It's something that I do similar with students in clinic. Is it's interesting all the information they tend to miss. They can really funnel the exam if they were actually listening. So, and some of these topics do touch on race and religion and a lot of other things as students. I mean, even seasoned clinicians are not comfortable talking about. So I think this talk has potential to sort of infiltrate the profession really early with our students as well as our colleagues, and just kind of keeping the conversation going in a motivational interview focus. And it can sort of divert some discomfort away from the topic, the hot topic, is to say, well, just approach it this way and talk about it this way. These are the types of questions you should ask to get these types of responses. And the toolkit does an excellent job with that. It's very specific. So highly encourage everyone to take a look at that toolkit.
Mo, I don't know if you intentionally tried to set our expectations low at the beginning of that, saying I don't have much to add, because there was a lot that was really meaningfully added there. So I'm really glad you decided to expand on that.
So Kevin, I have to say, this is what we did the whole time preparing for this talk. It was the back and forth, and thank you for allowing us to do that. And the sassing back and forth was fun too. So we truly enjoyed working together and bouncing off one another through this whole process. And I think any talk can be a little bit uncomfortable, but I will speak to my years of doing conference sessions. This is actually one of the most fun I have had, building new relationships with two women that I hadn't had the opportunity to know. And that was really the product of what came out within this presentation. So, I think we used an MI approach even when we started it. We just tell us our story, and that's where we started.
So, Ngozi, there was some mentions in reference to you by Mo a second ago regarding the ally component of it. And there was a position or positions of allyship. And I will say, as a white cisgender male, that one of the things that I go into these conversations more from when I witness microaggressions than anything else is what role of allyship is right. Am I drawing attention to myself? Can you help me understand the different positions of allyship?
Sure. I think that's a great question and something that needs to really be touched on. The quick answer to that is you should never center yourself if you're the ally. The underrepresented group is always going to be centered. So what that looks like is you as the ally either standing side by side with that underrepresented group or behind and supporting them in whatever way that you need to. How do you figure out how to support them? You ask. So you get out of the assuming role and start asking questions. What do you need? What can I do? That is the gist of it. That is the simplest, quickest answer to it. If we're going a bit deeper and we're talking about some of the types of allyship, that there are, the two that I presented or talked about in the presentation were the advocate and the champion. Both of those allies center themselves. The champion is, or sometimes called the saviors, is that performative allyship. They're doing it because they're more concerned about the way people are going to perceive them. They're just trying to save the day. And the champion, I'm sorry, the advocate, is more of a transactional allyship. that the advocate is doing this to get something out of it. That again, these two types of allyship are not centering the underrepresented group, and that's dangerous.
Thank you for clarification, and you tied back into previous mentions of finding out what a person is. Like they're like, where is that other person in the conversation at? And in this case, it's more of a what do you what would benefit you that I could provide to you? And I can only really get that answer if I ask. And that actually is a very impactful answer for me and hopefully for the listeners too. So this has been a wonderful, meaningful, and start of a fantastic discussion. I'm sure our listeners are going to want to follow up with you individuals or as a group to get more information on how we can continue down the right path and really learn how to meet everyone in the middle and then rise that middle ground to a better place. So that being the case, do you mind each of you giving us the best way to contact you? And we'll just ask Ngozi first. What's the best way our listeners can reach out to you?
Sure. I'd say email would be best. My email address is akatobi@gmail.com. That is my last name at gmail.com, spelled AKO, T as in Tom, AO, B as in boy, I @gmail.com. If you cannot tell, I have done that a very long time, spelling it out phonetically.
Thank you, Ngozi. Megan?
All right, I would say email probably as well. I have Twitter and LinkedIn as well, but Megan.Donaldson@tufts.edu. So Megan is MEGAN Donaldson, capital D as in dog, ONALDSON. And my Twitter handle is MDonaldsonPT. And you can find me on LinkedIn as well.
Thank you. And Mo?
Yep. So email is also easier. It's my first name, MOYO, the letter B as in boy, last name Tillery @gmail.com.
Thank you all, Dr. Tillery, Dr. Donaldson, Dr. Akataobi. It's been a wonderful conversation, and I really appreciate your time. And I hope you guys have a wonderful rest of your week and holiday season. And I will hopefully see all of you at the next conference. In person, hybrid if need be, but in person preferably, because I'd love to see you guys face to face. Thank you.
Thank you.
Thank you.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at AAOMPT.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym, AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.